Okay, so we're gonna go over some principles. We're gonna go over so there are a lot of rules when you're looking at musculoskeletal. Great. And there are a lot of rules. We're going to go. Yeah, I don't expect you to remember all this, but when you're looking at musculoskeletal X-rays, there are a bunch of lines that you need to remember. And if you have it in your repertoire, at least you then can look this up. And also, we're just going to quickly go over nomenclature, which is very important. So when you talk to the orthopedist, you can describe what you're actually seeing, so they get a good picture of that. Then a lot of these commonly missed fractures they're fairly uncommon, and that's part of why they're commonly missed. And we're not just going to go over fractures, we're going to go over some ligamentous injuries as well. And within there, we're going to go over some of the orthopedic emergencies. Next slide. Oh, okay. Okay, so thanks. So this
forward, back, and pointer. On the red one's the pointer.
Okay. Cool. Okay, so orthopedics comprises a large part of what we see, 10 to 20%, and it is the most common cause of a lawsuit. Is a missed fracture. It's not the biggest payout, but it is surprisingly, I think it's the most common cause for a lawsuit. The second most common is like missed foreign bodies. I don't know if that's actually gone down because I think we're so paranoid about that. But I think, therefore it is important to pay attention to reviewing these X-rays, because you may be the only person there looking at the X-ray. You may not have a radiologist. Just in general, when you're looking at children, their ligaments are stronger than their bone. The epiphysis is pretty weak, so it's very rare in a kid who still has open growth plates to say that they have a sprain. It's more likely to be a fracture. Be very generous when you're ordering X-rays for kids, because more than often, many times I have been surprised when a kid has a torus fracture when they had the most minimal tenderness, almost nothing, and they still will have a fracture. Whether it makes any difference, whether you find this, is questionable, but you certainly don't want them going someplace else and getting their X-ray there and finding that you missed it. Elderly are more likely to have fractures also than sprains, because they're osteoporotic and their limbs are, they're going to break much more easily than pull ligament. We're going to also go over some of the orthopedic emergencies, which are hip dislocation, which Meninder, he went over that. And so I'm not going to spend much time on that. But if it's a native hip dislocation, you are under the gun to reduce that before you develop avascular necrosis. That's not to say, and we actually had a case where a patient came in, I think they were unresponsive, they had a hip dislocation, we reduced the hip, and then he had some C-spine injury, which we didn't find, and had some long-term problem. So don't forget ABCs, but and limb is not number one, but you are just be cognizant of the fact that you do have a time frame. So femoral hip dislocations, femoral neck is something that we generally don't appreciate as being a time-sensitive injury in a younger patient, because when you see it in an older patient, generally we're not that concerned. Especially if it's displaced, we're going to just put in a new head and do a replacement of the hip. But in a younger person, you really want to avoid that, and the quicker you make that diagnosis and quicker you get them to the OR, the less likely they're going to have to get a hip replacement. And also, which we're going to get into, if the femoral neck is not displaced, it's important that you make that diagnosis early so that it doesn't become displaced and become a problem. Other emergencies, knee dislocations, really tough one because most of these spontaneously reduce, so they're hard to make the diagnosis. Compartment syndrome, sternoclavicular dislocation, which we're going to get into. Okay. Consider a more proximal source of problem if at the end of your assessment the clinical picture doesn't fit together. Ask the patient where it hurts most. If you can't reproduce the pain, think about another source. With knee pain, think about a hip or back. Hip fracture often presents with knee pain, and you can be led down the garden path if you're not thinking about that. Then look upstream. And I know Chertoff was mentioning this the other day in some follow-up rounds where the patient had some neurologic problem, and you're thinking this is neurologic, and you really should think it could be an upstream problem like an aortic dissection or some vascular problem causing a neuro thing. So this whole idea of thinking upstream. And then when you have a minor injury, don't rush it, really take your time. This is a case where I think this guy was, it's a site called emergencymedicinecases.com. It's out of Toronto, Canada. I actually like the site. They actually have a one-day course in February, which I'm considering going to, but I just can't bring myself to do it because for one day it's $850. Seems like a lot for one day, but maybe I should consider it as a donation to a good cause. Anyway, this case was for an ER doc who specializes in orthopedic. He runs an orthopedic clinic. He sees a 65-year-old guy, pain on the side of his knee, no hip pain, back pain. He's not complaining of that. He's tender along the medial aspect of his knee. He can do a straight leg raise, so we know his extensor mechanism's intact. X-ray shows some osteoarthritis. He gives him a diagnosis of an MCL injury. Then he sees him 1 week later in the ortho clinic using a walker. Goes, what's the matter with this guy? And at that point, they examine him, and he has a subcapital hip fracture, which was non-displaced before. Now it's become displaced, so he needs to go to get a hip replacement. So, just important to keep in your mind when they come with knee pain, you should always think about it could be hip. And I think there's another caveat. It's important to focus on the point of maximal tenderness. And I think this guy's mistake, part of it was pressed on the knee and he says, yeah, it hurts there, but is this really the pain that you're having? Is this really the exact spot where you're having maximal pain? So it's important to establish that. They may have two injuries. This may not be the primary injury. So you should really establish with the patient where they're having maximal pain. And if you're not actually able to reproduce it, then think about the pain may be, more proximal. That's a red flag where you can't reproduce the pain. You need to look elsewhere. Examine the joint above and below is always a good idea. And then in terms of examining the joints, in a kid or an adult, it's always good to go to the most tender area, what you're suspecting last. In a kid, they're going to not let you examine them anymore if you go to the first one to the most tender place first. And in an adult, they may develop some spasm. You may not be able to examine the rest. So it's always just a good practice to examine what you think is the most painful area last. Neurovascular exam is critical and is becoming an issue if you don't do it before and after. Let's say you're going to reduce a dislocation. Any break in the skin in the region of a fracture is an open fracture until proven otherwise. So it's important that you undress the patient so that you can really visibly look to see that the skin's intact, and if there's any break in the skin, assume that it's an open injury. When you have a displaced fracture, tenting the skin, this is a problem because there's going to be a lot of swelling, and even though it may not be an open fracture, with a tenting of the skin, it may progress to break through the skin, and now you have an open fracture. So it needs to be reduced early when you have, displaced or an angulated fracture. Where there's limited tissue over the, let's say, a tibia, over the shin, that's an area where you need to reduce a very little skin. It could break through very easily. So don't leave displaced fractures. There's always a question of what can be seen the next day, and most things can, but if it's really displaced, it really should be reduced. In terms of RICE, the R stands for restricted activity, not no activity. And then this whole idea that your soft tissue injury, which we kind of minimize, can really be the major determinant of how long it's going to take for them to recover. And where the ligamentous injury is critical. Like if you have a little avulsion fracture on your distal fibula, that means you probably have strained, it's an avulsion fracture involving your anterior talofibular ligament. It's like a sprain. It's nothing serious. But if you have a teardrop fracture in the neck with the anterior longitudinal ligament, that's much more concerning. This is just something I've seen a lot I've seen this in urgent care where a patient comes in to get their sutures taken out after having a laceration on their finger, and I happen to see if they can flex their finger, and they're unable to flex it because they have a flexor tendon rupture, and I think the person who initially saw them attributed to their inability to flex their finger to pain. That is like in all these cases, it's a diagnosis of exclusion. If they can't bend their finger, assume, if they can't do whatever, if they can't plan or flex, and you're saying it's because it's due to their knee or due to their, some pain, always give them a lot of pain medication and see if you can overcome that. But, at least have them follow up with hand if they're really not able to flex their finger. And in addition, if they're able to flex it, but it causes a great deal of pain, it may be a partial flexor tendon injury. So consider that they need to get referral. Just in terms of reduction, remember, this is not a sudden thing. This is a steady, slow, gentle, movement, and wait for it to just gradually come in. And we're going to go over a couple of these reductions, but sometimes you need to actually increase the deformity to unlock the fracture or displacement. When you have a Colles fracture, the direction of the displacement is in the direction of the force of injury. So the fouche, the wrist displaces dorsally. When you reduce it, you have to push it volarly and radially. So it's going to tend to want to go back dorsally. So when you put your splint on, you want to put it on in the opposite. I think this happened once before for my lecture. So you want to put your splint on in the opposite direction of the direction of where it tends to destabilize. So in this case, in a Colles fracture, you want to put your splint on volarly. And, Sarah Goldman, I know she gave a talk last year. Ideally, if it's really going to likely to if it's unstable and likely to shift, using plaster is you can really mold it much better than orthoglass. So if you have it, that would be a much better way to go. Okay, and just in terms of quick neuro exam, how does it go? Oh, if you can put your thumb up and make flex your fingers, that's the radius and median nerve are intact in terms of motor. And if you're able to do the OK sign, where you are extending your fingers apart and you're able to bend your DIP on your index finger as well as your thumb, and that it means your ulnar nerve and your anterior interosseous nerve are all intact. So, simple little maneuver to make. Okay, and just in terms of x-rays, order the right x-ray. If you're really looking at a finger, don't order hand. But if you're really not sure if it extends back more proximally, that's fine, get the hand. But it's always nice to zero in on what your injury is. Getting a long bone forearm, when your real questions about the elbow more proximally, you get a better x-ray doing ankle. And then a lot of times, people will order the x-rays before you see them, and really when it's a foot problem, they'll order ankle or vice versa. So make sure you're getting the right x-ray. You got to get 2 views. And in terms of true laterals, when you're getting an elbow, we're going to show some x-rays, but you really need to have that hourglass or figure of 8 to really know that you have a true lateral. And that also applies to when you're doing a Y view on a shoulder. The scapula should be narrow. If it's wide, it's not giving you a true lateral. Then there are all these views you should be familiar with. The sunrise, if you're really looking for patella fracture. The tunnel view, if you want to see the tibial spines in there. There's a scaphoid view where where they deviate the wrist ulnarly. There's a calcaneal, also called an axillary view. Calcaneal is called a Harris view. And then the axillary view for the shoulder is absolutely critical that you're familiar with this, because sometimes on posterior dislocations, you're not going to see that on your Y view. So you need to know about these different views. If you really have a high clinical suspicion, your x-rays may be negative, you may need to move on, but there's certain things which are very classic to miss, and that's like radial head, scaphoid. If your x-rays are negative, you really need to at least splint them and refer them to ortho. The most commonly missed fracture is a second fracture. Just because you find the first fracture, don't give up. Keep looking, because there may be a second one. And know your common variants. And then a lot of times you're going to see things on the x-ray which don't correspond with your clinical exam. If they're not tender where you're seeing something, then it's most likely an old injury. Knowing the most frequent sites where they're going to be fractured, this is really critical. So you know where to zero in on. Like when I'm looking at an elbow on an adult, what do I zero in on? Radial head. That is where their most fractures are. And if it's a kid, I'm looking at supracondylar, because those are where the most common. That's where, Sutton said about, why do you rob banks? Because that's where the money is. On the x-ray, you got to know where the money is. And also, when you're looking at your x-rays, it really does help to know all your bones. And there's certain places where it's very confusing. The foot, the mid part of the foot with the cuboid and the cuneiforms and the navicular. But it's helpful and really makes it a lot more interesting if you know these, as well as the carpal bones in the hand, which are classic areas where you're going to screw up. Knowing what's commonly missed, we already went over that. And a lot of this we've already gone over too. And then we're just a quick thing on nomenclature. Open, which is also referred to as compound, means it's open to the skin. Location, when you're looking at a long bone, it's described as proximal, mid-shaft, or distal. Long bones, you want to know if it's intra-articular. That's key, if it's involving the joint space. If it's comminuted, which means more than two. The fracture pattern, transverse, oblique, spiral. Oblique and spiral are very similar. I think they're hard to really differentiate. We have some pictures, avulsion fractures, impactions may be very difficult to tell, but there are going to be certain signs we'll go over. And dislocation, complete incongruity. There's no touching of the articular surfaces. Subluxation is an incomplete articulation joint surfaces. Displacement doesn't involve the joint. And we're going to show some slides of this, but what's key is when describing the direction of dislocation, subluxation, or displacement, describe the distal anatomy relative to the proximal. Okay, can you guys see this? I'll give you this. We're looking at a knee. Okay, so what kind of dislocation is this? Anterior, right? Because here the tibia is anterior to the proximal humerus. Okay. Okay, what kind of dislocation is this? Looking at the elbow. Posterior. Okay, so you guys all know that. Okay, and then in terms of displacement, distraction, shortening. This is non-displaced because it's not moved over, though it is separated a bit. And then you describe medial or lateral. It's shortened, overriding. And then it can be angulated, and you describe this is lateral displacement and lateral angulation. Just important to know that. And then in terms of aftercare, if a person is just putting on their jacket and they dislocate their shoulder, that's minimal trauma, and it's probably not going to need to be immobilized for very long. Whereas if it's more, a more traumatic injury, that will take longer to heal. And it's important, obviously, the person who we're going to go over this, but the person who just has minimal, injury, they were just putting on their jacket and they dislocated their shoulder. That kind of person, if they have had recurrent dislocations, they're not 70 years old, that patient, you may not even need to get an x-ray. But I wouldn't do it on an older patient, because even the most minimal movement dislocating the shoulder could cause a fracture. So I would do it on a younger patient. It's an obvious diagnosis. They have a normal neuroexam. You do a very gentle reduction, not really concerned that you broke anything. You have no question it's reduced. They're able to do full range of motion. If they have all of the above, you really don't even need to do x-rays.